All right, now we're on to Chapter 12, which is going to be Surgical Interventions and Post-Op Management. So why someone would decide to get surgery? One of the first reasons is that their conservative program was unsuccessful. So what that means in lay terminology is that they have tried PT and medicine and anything that they can possibly think of, and they're still having pain or whatever the problem is. So they've tried non-operative management and it's not working any longer. If someone has pain at rest or with functional activities, most people can handle, pain with movement. You understand that. But if you're just sitting still and not doing anything and it still hurts, that might mean that there's something more serious underlying going on. Or pain with functional activities. We have to function. So if doing just normal everyday things hurt, again, might be time for surgery. So again, before I get through any more of this list, really surgery should always be the last resort. And for most people, it is. So again, it's once they've tried everything else, once they're just having too much pain that they can no longer deal with it. If they have significant limitations in range of motion, gross instability of a joint, if the joint is deformed or malaligned, surgery might be the only option or the only way to get it back in alignment. If there's structural degeneration, chronic swelling, or any other just significant loss of function that can lead to disability, then it might be time to consider surgery. So if we can manage to see our patients before they have surgery, that's ideal. It doesn't always happen because of insurance, but some of the benefits of having a pre-op program are that we can establish baseline before the person even goes in for surgery. We can help to sort of prioritize their needs and their goals for once surgery occurs. We can just build that rapport with them so they know who their therapist is going to be after surgery. And give them some education about the surgery as well as rehab. So if there's things that they can start immediately, or just so that they know what to expect, what will be done right away, what will come a little bit later. We can also take some tests and measures, again, pre-operatively to get that baseline, so figure out what their pain is, what their range of motion and strength looks like prior to surgery. What's their posture? What's their gait look like? Functional status? All of these things, again, just to give us a baseline, give us an idea of where we are starting from before the person goes in for the surgery. As far as patient education goes prior to surgery, just kind of go over the plan of care with them, like this is what is to be expected after the surgery, this is what we're going to do in therapy, this is how long you'll be in the hospital, this is what you'll do when you're in the hospital, this is when you'll go home, and what sort of things you'll do there. If there's any precautions for things like total hips, there are some precautions for total hip replacements that we want to go over with them to make sure, again, to go over with them before surgery when they're not all hopped up on medication and stuff like that might be a better idea than immediately post-surgical, just so that we can make sure that the patient understands what's going to be expected of them. A lot of times post-surgery, bed mobility and transfers are going to be affected. So we can even start to practice with our patients ahead of time, or at least, show them and teach them how they're going to get in and out of bed, how they're going to get themselves around. Teach them some initial post-op exercises, regardless of kind of what surgery our patients are going to have. Deep breathing exercises, ankle pumps, isometrics are probably going to be what they're expected to do immediately after surgery. So again, any instruction in that ahead of time is usually beneficial. Gait training, gait may be affected following surgery. So we will want to show them if they're going to need assistive devices, we can go ahead and get those for the patient, fit them, show them how they're going to walk with it. It's one less thing for them to have to worry about immediately following surgery. We may also go over some basic wound care techniques with our patient, or just even some things to look for, teach them what to look for to make sure that the wound's healing properly following surgery. So the phases of post-op rehab we have touched on a little bit before, but they can be described several ways, like the phases of tissue healing, the level of difficulty of activities, the degree of protection, or just numbered. Phase 1, phase 2, phase 3. Sometimes if there's protocols associated with a particular surgery, you'll see that the phases of that are numbered. So early post-op, initially our goals are just to try to minimize pain as much as possible. Typically following any type of surgery, a patient's going to report pain, and they're probably going to be given some decent pain medications to deal with that. We want to try to prevent any post-op complications, and we'll get into what some of those complications might be here in just a minute. And we also want to make sure that our patient's going to be able to safely function in this incapacitated state until they're feeling a little bit better. Then as the patient does progress and get better, we're going to work on improving range of motion, strength, neuromuscular control, balance, endurance, and get them back to their functional activities. So in the maximum protection phase, or the acute phase, or usually phase 1, post-surgical, the patient may be immobilized depending on the type of surgery that they had. Immobilization is not always indicated. Sometimes we do want to get them moving right away. Total hips, total knees, often not immobilized. Rotator cuff repairs, often immobilized. So it's going to be totally dependent on what type of surgery your patient has and the physician. The physician is really the one who's going to determine whether or not your patient's immobilized following surgery. We can usually put some low-level stresses on the tissue as it's starting to heal. So we might do some early passive range of motion or even active assisted range of motion in a protected range. So again, we're not stretching at this point. We're not even really pushing the limits of range of motion at this point. We're just trying to get them moving a little bit in the range that they currently have. And again, within the patient's tolerance. We may be able to do some isometric or muscle setting exercises at this stage. And again, this can last anywhere from a few days up to about 6 weeks, depending on the tissues involved and the severity of the surgery that happened. Then we usually move into the moderate protection phase or the subacute phase. Again, this is when inflammation is going to subside. The person usually reports minimal pain. Again, maybe pain at end range, a little pain with movement, but generally they're feeling better at this point. Tissues are able to handle some increased stresses here. The criteria to move into the moderate protection phase, or how we know someone is in the moderate protection phase, is when they have no pain at rest, so their pain has subsided, and they do have some pain-free range of motion. It might be limited. Again, they're not going to probably have full range just yet, but there is some range that they're able to go through without pain. So our goals during this phase are to try to get as much normal range of motion as we possibly can, improve their neuromuscular control and stability, and begin to increase their strength. So this is typically 4 to 6 weeks post-op and then continues for another 4 to 6 weeks beyond that. And then we'll move into the minimum protection phase or the chronic phase. So the criteria to progress into this phase is full or almost full pain-free range of motion. So we've restored the majority of their range of motion by this point. They have a stable joint capsule and they have the strength, or at least some strength, as compared to where they started from. So usually the goals in this phase are to continue strengthening, to get them back to whatever activities they need to get back to. So we're going to progress their functional activities. So this is the getting them back to work, back to school, back to sports, back to independence, whatever it is that we're trying for our long-term goals for these patients. So the time frame for this is going to be about 6 to 12 weeks post-op, and then it can last 6 months or beyond, again, depending on the type of surgery. From what I've heard, most surgeons and most physicians will usually tell people it's going to take a good 9 months to a year to feel totally 100% back to normal following a major surgery. So some potential post-op complications and some things we want to be cognizant of when we're working with our patients. Pulmonary complications, DVT and pulmonary embolism, which we've talked about a little bit. We're going to talk about a little bit more about today as well. Subluxation or dislocation after a joint surgery, adhesions or scar tissue formations, or failure, displacement, or loosening of an internal fixation device. So let's start with DVT. Risk factors for developing a deep vein thrombosis are going to be post-op immobilization. So again, as long as it's safe to move the patient or to get them moving, we want to try to get them moving. There are going to be some surgical conditions where that is just not possible. We need to let the operated tissue heal. So again, go with what the physician says for this. Someone who's on prolonged bed rest, sudden sedentary lifestyle or long distance travel can lead to increased risk for DVTs. If they've had cancer within the past 6 months, they're at an increased risk. If they've had a previous DVT, and this is a big one, they had the conditions in place before they developed DVT, they are more likely to develop another one. If there has been any trauma to the veins, The older they are, the more likely this is to happen. If they have congestive heart failure, if they are obese, oral contraceptives, birth control, also increases the chance of blood clot formation. Pregnancy increases the risk as well, as does limb paralysis. So if your patient has any of these risk factors, we do want to be especially careful as we monitor them following surgery. So being able to recognize if someone has a DVT, this is very important. They are typically going to report pain. It can range anywhere from dull to severe. It's usually more of an achy type pain. There will often be swelling. It may be too deep to palpate. There'll be changes in skin temperature and color. You usually see some associated redness in the area. Non-specific, constant knee or calf pain. It is most common to develop a DVT in the calf, although they can develop in the upper extremities as well. So if it is in the calf and the lower extremity, they may report tenderness with dorsiflexion as well. There is a special test, it's called Homan's sign, that's used to test for a DVT. And basically what you do is you kind of just squeeze the calf. If you squeeze my calf, I'm probably going to have a positive test, even though I don't think I have a DVT. So it's not the best test. So we really go more with the signs and symptoms that our patient presents with. And one of the complications of a DVT is that we don't want it to turn into a pulmonary embolism. So a DVT is a clot that develops a deep vein thrombosis, and then it can travel. And if it travels to the lung, this can be a pulmonary embolism. So signs and symptoms of a blood clot in the lungs would be a sudden onset shortness of breath, rapid shallow breathing, lateral chest pain, so pain in the chest wall that's worsened by deep breathing or coughing. They may have some swelling of the lower extremities, especially if there are remaining blood clots in the legs. Anxiety, clearly, right? They're having a hard time breathing. Fever or excessive sweating, and blood, they can cough up blood, are all signs of a potential pulmonary embolism. All of these require immediate medical attention. So ways that we can reduce the risk of DVT. Most patients following any type of major surgery are going to be given proactively anticoagulant therapy, blood thinners so that they don't develop a blood clot while they're healing, elevation of the lower extremities, compression we'll talk about. So down at the bottom, compression stockings, sequential pneumatic compression. Oftentimes patients will wake up from surgery with compression garments on their lower extremities, whether it's a machine or compression stockings, to make sure that they don't develop blood clots. Ambulation as soon as possible. So this is why with most of our patients, as long as it's safe for them to be up and weight bearing, we are going to get them up and walking either post-op day 0, so the day of surgery, or post-op day 1, which some people think that's crazy. Some patients are going to think that's crazy, but it's very, very important. And the sooner they can get up and walking, the less chance of these complications developing. If you do suspect that your patient has a DVT, refer them immediately. If you're still in the hospital, you have all the medical professionals around you, have them get checked out. Make sure you document what you have found as well, and talk to nursing about getting them evaluated. Medical management of DVTs includes increased anticoagulants, so blood thinners, again, to try to dissolve that clot to make sure that it doesn't travel anywhere else. And they may actually be put on bed rest. It may last a day or two. It may last even longer than that. They will most likely be given compression stockings, and active exercises are going to be contraindicated. For the most part, PT is usually put on hold until the patient has begun anticoagulative therapy and they are sufficiently anticoagulated. There are some recent studies that show ambulation is okay, but I would just, I usually err on the side of caution and make sure that you know what your facility's expectations are. All right, so let's get into some surgical interventions. So surgical approaches, we can either have a full open surgical approach or we can go arthroscopically. And I say we, I mean the surgeons. So an open means that they're fully going to open up and visualize the area as to which they're performing surgery. So it's a large, deep incision through the skin, the muscles, possibly even the joint capsule if it's a joint surgery. The full field is going to be visible to the surgeon, so we need an open procedure for things like joint replacements, an arthrodesis, which is a joint fusion, internal fixation of a fracture, and some soft tissue repairs or reconstructions may need to be opened up. With an open surgery, we do definitely have more damage to the soft tissue, so rehab generally tends to take a bit longer. So if it's possible, we'd like to do arthroscopic approaches to most of our surgeries. This is when we do surgery through several small incisions or portals. There's an insertion of an endoscope, which is the camera, so that they can visualize the tissues. And then there's little small motorized surgical tools. They have names. I name them for what they do. So there's like a little chomper thing that can cut off the dead tissue. There's a vacuum that can suck out what we don't need in there anymore. And there's also tools that will repair the tissues. So again, we can remove loose bodies, debris joint surfaces. We often see arthroscopic surgeries for ligament, tendon, capsule repairs or reconstructions, meniscectomies or synovectomies, as well as debridements. And we'll get into some of the specifics of each of those procedures here shortly. Types of tissue grafts. We might see tissue grafts with our patients. Autografts are going to be the patient's own tissues. For ACLs, this is pretty common. They will harvest usually either patellar or hamstring tendons from that person in order to reconstruct an ACL ligament that has been torn. Allografts are going to be your cadaver tissue. If there's been a previously failed autograft, so they've already taken your tissue, they don't want to take it again or take any more tissue than they need to, or if there is not an appropriate donor site, then they might use cadaver tissue. There's also some synthetic grafts that they can use, like Gore-Tex and Dacron, but they have a much higher failure rate than using either autografts or allografts, so those aren't done nearly as commonly. Muscle repairs. Muscle repairs for avulsed muscles are usually performed within 48 to 72 hours after injury. They don't want to let these go too long because when a muscle avulses, it's going to retract, it's going to kind of ball up, and the longer you leave it there, the harder it's going to be to stretch it back down and reattach it. So the muscle is going to be reattached, sutured, and then usually immobilized in a shortened position. So if you think way back to modalities, we talked about immobilizing, and ways to prevent atrophy was to immobilize in a lengthened position. Because of the type of surgery here, we're reattaching a muscle or reattaching a tendon, it has to be immobilized in a shortened position to allow it to heal. With that being said, that probably means there is going to be some atrophy and some weakness of that muscle post-op. So post-op management, if we're able to perform isometrics, we might not be able to, especially if the muscle that was just reattached, we want to give it some time to heal and not pull on that muscle or have that muscle contract for a period of time. But you can do exercises of the surrounding musculature. Once the immobilization is removed, we can begin some motion. They may have limited weight bearing for a period of time, so they may require some assistive devices for a period of time. We will begin with more muscular endurance type activities, so low load, high reps for resistance activities. And vigorous stretching is typically contraindicated until they're fully healed, which is going to be at a minimum 6 to 8 weeks. Tendon repairs, tendons avulse, again, usually as the result of trauma, especially in a younger person. With an older person, it could be trauma, but it could also just be progressive deterioration. It usually ruptures at either the muscular tendinous or the tendon osseous junction, which is where the tendon attaches to bone. Some common sites are going to be the bicipital tendon at the shoulder, the Achilles tendon, and the superficial tendons of the hand or the foot, which is oftentimes due to some sort of laceration or cut. A full tear, the patient will be unable to generate a muscle contraction. Again, there's going to be little pain because it's no longer attached. Following that acute phase, obviously it's going to hurt pretty significantly. In the beginning, just attached a tendon. But then once that sort of subsides, then it's usually not quite so painful. With a partial tear, every time that muscle or that tendon contract, or the muscle contracts, it's going to pull on that tendon, and that is going to be painful. So again, these are often going to be repaired within days, again, or the tendon may retract. It's going to be sutured, and then the person will be immobilized in a shortened position. Immobilizations for these can be quite lengthy. Tendons don't have a great vascular supply, so it takes them a little bit longer to heal than muscles would. We will try to move them, remobilize as early as possible, usually, again, within a protected range of motion. There will often be a protocol for these surgeries sent by the physician, so make sure you're following that. And they, again, will usually lay out, they're only allowed this much motion in this phase of rehab. Once they progress to here, you can increase to this much motion. But we do want to try to prevent any adhesions from forming, so we do want to try to get them moving in a protected range. Again, if we're allowed to muscle set, do isometric exercises, we will, but sometimes that is going to be contraindicated depending on the type of surgery. Sometimes we can take the immobilization off. If they're wearing like a sling or a boot, that's removable. If they're in a cast, that is not removable. So it just depends on the type of immobilization, if we can take it off or not to do some passive motion. Begin some controlled anti-gravity motions after several weeks. So once we've started to heal a bit. Usually there are weight-bearing restrictions and no heavy lifting for 6 to 8 weeks. And just long-term, know that full range of motion may be difficult to achieve with these patients. Because that tendon has detached, they had to reattach it. They probably had to come up a little bit on the tendon in order to pull it down. So it may be a little bit shorter now than the other side. So it might be difficult to get full range of motion back. Plus, we usually have to wait until it's healed a good 6 to 8 weeks before we can really begin to stretch it out. So it's going to tighten up in that time as well. So ligament repairs or reconstructions, the joint again is going to be immobilized in a position, usually shortened, that puts a safe level of tension on that healing ligament. How long it's immobilized is going to vary, again, depending on which ligament it is, what type of surgery it is, if they needed to graft, all that kind of stuff. So there's a lot that can play into that. Immediately post-op, we're trying to introduce some protected motion, progressive resisted exercises as PREs, and weight bearing to load the healing tissues as safely as we can. So again, it might be restricted, it might not. But the person will most likely demonstrate reduced weight bearing if it's lower extremity. Again, progression is going to depend on the type of repair, the site, what all was involved, and how significant the repair needed to be. And weight bearing restrictions may be in place for quite some time. Again, this is generally a lengthier process, 6 months to a year to return fully to work or sports. So what I'm thinking here is like your ACL reconstructions, right? Usually those take a good 6 months to a year to get back to high demand work or sports. All right, so capsule stabilization and reconstruction. So this would be for a joint capsule that is excessively lax. So this would be someone who has chronic instability, someone who subluxes or dislocates a lot. The shoulder is probably the most common joint for this to happen in. It could be due to just congenital deformities of the shoulder or some sort of injury to the capsule itself, repetitive stresses. Sometimes we see people with like looser shoulders, sometimes like our swimmers, gymnasts, people who are using a lot of shoulder range of motion, pitchers or throwers often have excess motion in a shoulder and can actually end up stretching out the joint capsule, which makes that shoulder more unstable. So we will have surgery, or surgery is going to be indicated if there is a capsular avulsion, a labral avulsion, if there's a fracture within the capsule. And as we get into the shoulder, we'll talk about more specifics with that. Someone who recurrently dislocates, their shoulder dislocates multiple times. If it subluxes and it's symptomatic, so it sort of slips out of place and then the person has pain or problems because of that. Or if it's an irreducible dislocation, so that means it's a dislocation, it has come out of joint and it doesn't automatically go back into the joint. So the person can't sort of relocate their own shoulder. They may have to go get medical intervention for that to happen. So surgery can be open if there's extensive damage, or it can be arthroscopic, again, just depending on what they need to repair inside. So some examples would be a capsulorrhaphy or a capsular shift. This is when part of the capsule is incised and tightened. So what they kind of do is they just sort of overlap the capsule on itself, suture it up to shrink it, basically, to make it smaller and tighter and to make that shoulder more stable. They can do a capsular labral reconstruction. So this is usually if the labrum tears, which sometimes when the shoulder dislocates, it may tear part of the labrum off with it. So they'll reattach the labrum and they'll stabilize the capsule at the same time. And they may do an electrothermically assisted capsulorrhaphy. This is basically where they use a laser to shrink the capsule. So it's the same thing, but instead of using sutures like in a traditional capsulorrhaphy, they'll use a laser to shrink the tissues. So post-op, We want to make sure that we're getting enough motion back, but the problem was this person probably had excess motion going into surgery. So we're going to make sure they don't get too stiff post-op, but it's going to be within a protected range. They may or may not be immobilized. I have seen some patients following capsulorrhaphies of their shoulder. And again, it just depends on how unstable they were going into surgery and what surgical approach was used. So again, early range of motion within a protected range. We're not going to be going to the full ends of range of motion just yet. And then we want to make sure that we strengthen them as well. They need lots of stabilization at the shoulder, so we can teach them exercises to make sure the muscles surrounding the shoulder are good and strong as well. Tendon transfers or realignments. This can alter the line of pull or force generation of a muscle. It doesn't necessarily change the action of the muscle, but it could. And it can also help to improve the stability of a joint. This is not a super common procedure, but you might see it with some people following neurologic injuries because it can actually help to increase their function. So what they'll do is they will remove the end of the muscle and they'll reattach it somewhere else. Immobilize it in a shortened position. Rehab is going to look like the things that we've just talked about. But the idea here is that we can maybe make up for paralysis in one site by reattaching a muscle somewhere else, maybe help with orthotic or prosthetic use. So it's really something done to increase your patient's function. Post-operatively, again, if we can do early isometrics, we will. That might not always be allowable after surgery. Range of motion within a protected range, and then a slow, gradual progression of resisted exercises. If you are changing the action of the muscle, if the surgeon has changed the action of the muscle, we might need biofeedback or e-stim to sort of learn control of how to fire that muscle now to do what we want it to do. Release, lengthening, or decompression of soft tissue. So this is usually used to improve range of motion or to fix a deformity that has occurred. So one thing that can happen, or one procedure, is called a Z lengthening. I have seen this used on some children with cerebral palsy. I've seen it used on the heel cords, so the Achilles tendon. So what happens sometimes is children with CP have what we call spastic diplegia. Their legs are in more of an extensor-based pattern, and they tend to walk up on their toes, right? So their heel cords actually get shortened, their Achilles tendon gets shortened, and that forces them to be up on their toes. So sometimes what they'll do is they will do what's called a Z lengthening procedure, where they will go in and they will notch one side of the tendon and then the other side of the tendon, and then they pull on it to lengthen it. And then they let it heal that way. So these kids will often be immobilized in a lengthened position following surgery because that's our whole goal, is we're trying to lengthen that tendon to give them more function. I have also seen this done on adductors, because with that spastic diplegia in that population, their adductors can also get really tight, which causes them to use that scissoring type gait, and can also lead to some hygiene problems if it's too tight. So they can go in and do the same thing. They can lengthen those tendons a little bit, and then they'll be immobilized in a lengthened position. We might have them immediately on CPM machines after surgery, or doing some active assisted range of motion immediately. We want to get these people moving and keep that length as much as we possibly can. We will strengthen the antagonists, again, to try to keep as much of that length. So using the example of a tight Achilles that has been lengthened, we will try to work on dorsiflexion as much as we can to try to keep that tendon in a lengthened position. And then again, functional activities as much as possible, and trying to use that new length in functional activities. So trying to get that child walking with their heels down on the ground. That's going to be a very functional activity, which will help to maintain the length of that tendon. All right, so we'll get into some joint procedures here to finish up. Arthroscopic debridement, synovectomies, articular cartilage procedures, arthroplasties, which are joint replacements, arthrodesis, which are joint fusions, ORIF, which stands for open reduction and internal fixation, and osteotomies. So debridement and synovectomies. Debridement is typically done arthroscopically, removal of cartilage, unstable chondral flaps, loose bodies, osteophytes. One of the more common procedures that I can think of that you've probably heard of is meniscectomies, right? So removal of part of the meniscus because meniscus doesn't have a lot of vascular supply. They don't heal very well. So if it gets torn, and it's not repairable, they'll go in and they'll just remove the part that's torn. So this is a debridement. One of the symptoms of a meniscus tear is feels like a catching or a locking sensation and joint pain. So by removing that flap in there, this should help to relieve those symptoms. Synovectomies are commonly seen in patients who have rheumatoid arthritis at the knee, elbow, wrist, or the MCP joints. This is an actual removal and debridement of the synovium. So this is, again, generally done to try to improve function and relieve pain. So post-op, we want to do some range of motion, and isometrics can usually be done right away. A quick progression to active range of motion. They're usually full weight bearing pretty quickly. If it's an open procedure, progression is usually a little bit slower, but for the most part, most of this is done arthroscopically. And again, depending on how the patient responds, they may move a little faster or slower, but this is generally a pretty quick rehab, and make sure that we're avoiding any exercise that makes them feel worse. Abrasion arthroplasty, subchondral drilling, and microfracture. All of these procedures are done to stimulate bone growth. It's used to promote healing of small chondral defects, so to kind of almost reverse the effects of arthritis. So it's seen with the patella, the medial femoral condyle. Like I mentioned earlier, the medial side of the knee tends to wear down faster than the lateral side. So by doing this abrasion arthroplasty, they drill into the bone marrow to try to stimulate more bone marrow to grow in its place. Microfracture is a little bit of a newer technique. It's a non-motorized tool that penetrates down into the subchondral bone, again, trying to stimulate more new bone and more cartilage to form in this area. This is typically done as a way to buy someone time before having to have a total joint replacement. Chondrocyte transplantation is another treatment technique that's used in patients who have wearing away of the cartilage, so osteoarthritis. So the idea, again, is to try to stimulate the growth of hyaline cartilage and prevent deterioration of the joint space. So healthy articular cartilage is harvested usually from a non-weight-bearing site. Oftentimes they'll take it from the top of the iliac crest or within the ilium itself because that's not really a weight-bearing surface. And then they will culture it in a lab and try to grow more chondrocytes. So it's a sort of a self-transplantation. They're taking the person's own healthy cells, multiplying them in a lab, and then reimplanting them into the knee or whatever joint it is that is wearing away. It does require an open procedure. The chondrocytes are injected underneath a patch, and then that patch is usually dissolvable within the site. Osteochondral autografts and allografts. Again, this is transplantation of intact articular cartilage with possibly some of the underlying bone as well. So an autograft, again, is going to be harvested from the patient's own donor site. What they do is what they call a mosaic plasty. So they just take kind of like little bits and pieces, again, from a non-weight-bearing surface, and then they use them to kind of make a bigger patch to put into the site that needs it. They can also use cadaver tissue for this. However, it has to be done almost immediately because freezing kills chondrocytes, so they can't last. So it has to be really taken from the cadaver and then used right away. Your rehab for this is going to be pretty slow post-op because we have just sort of reimplanted those weight-bearing surfaces. So we'll begin with passive range of motion, maybe CPM, protected weight bearing for a period of time. It usually takes a good 8 to 9 weeks to be full weight bearing, and then resistive exercises are going to continue 6 to 12 months, so quite some time afterwards. Again, this is basically like a cartilage transplant. It's not done all that often because the rehab does take so long, and it's really, again, just trying to buy the person some more time before they would need a total joint replacement. An excision arthroplasty is removal of bone from one or both joint surfaces. It's a reconstructive joint procedure. It can be done with or without a joint implant, and the idea is we're going to try to decrease pain and increase function. So when they remove the bone, they leave a little bit of space. Scar tissue will form in that space, and that will sort of take its place. It can be performed at the hip, elbow, wrist, and foot, and where we see it now is either in resection for the radial head for severe arthritis or a comminuted fracture, and we'll talk more about radial head replacements and things like that when we get to the elbow chapter, or potentially as a salvage procedure for a failed total hip replacement, and they can't revise it or can't do another fix for it. So some disadvantages of this is that obviously there's going to be some joint instability, and there may be a leg length discrepancy and muscle imbalances following surgery. If there is an implant, that artificial implant needs to be fixed in place somehow. It's oftentimes a flexible silicone material that will become fibrotic as the person heals, but this is going to be a lengthy process. So again, these are not super common procedures because of the length of rehab afterwards. Interposition arthroplasty, again, not very common. It's a biological joint resurfacing technique to provide a new articular surface or to increase the pliability of the articular surface. So the joint surface is going to be debrided, and then some material, silicone, metal, is put in its place. And sometimes they'll do this with younger people where they don't want to do a joint replacement yet. They do try to prolong joint replacements or put them off as long as possible because you can only have so many of them within your lifetime. So that brings us to joint replacements. Joint replacement arthroplasty is the total joint, or we can also have hemi joint replacements as well. So that's when you're going to resect or remove both articulating surfaces and replace them with artificial components. A hemi replacement would just be removal of one surface. So there's multiple materials, designs, and methods used. There's metal alloys, plastic, ceramic pieces. They can be unrestrained to fully constrained. Most total knees and hips are unrestrained. Fully constrained or articulating means that there's some sort of pin or there's some sort of connection between the two pieces. Fixation can be either cemented or non-cemented. For most older people, they will use a cemented technique. They'll put joint cement in there, and then they put the artificial replacement piece in. With a younger person, if they're doing a total joint replacement, they will oftentimes use a non-cemented procedure. So what they do is when they drill in and put the new prosthetic piece in, there's holes in the prosthetic, and the bone can start to grow into those holes. And there is less chance of that prosthetic loosening down the road. That is why most joint replacements eventually fail. That's why they say joint replacements are good probably for a good 15 to 20 years now. But what happens is over time, wear and tear on those joints again, the metal starts to come away from the bone. They eventually start to loosen up. So if it was cemented, it might need to be revised or replaced 20 years down the road, which is again why they try to put these off as long as they can. So in a younger person, by doing a non-cemented and letting the bone grow into it, that joint replacement should last a little bit longer that way. Minimally invasive arthroplasties, again, smaller incisions, less damage to the muscles, less damage to the capsules. They are looking at procedures for the hip and the knee this way. However, most surgeons are going to only cut as much as they need to anyway. Ideally, again, the smaller the incision, the faster they're going to heal. With this minimally invasive joint replacement, they found less pain, more motion, shorter hospital stays, and quicker recoveries. Contraindications to total joint replacements are going to be if your patient has an active infection or osteomyelitis, systemic infection, if there is significant loss of bone or malignant tumors in the bone which they're trying to replace. When we get further into the chapters, I have some video diagrams of what joint replacements actually look like. They are putting prosthetic metal pieces down into the long shafts of these bones. There has to be sufficient bone stock for them to do that. So if there's a lot of bone loss or they have cancer in those bones are going to be weak, frail, more likely to fracture when they try to put these replacements in. If there's paralysis of the muscles surrounding the joints, might make rehab a bit more complicated. A neuropathic joint or inadequate patient motivation. Not everyone is going to be an ideal candidate for a joint replacement. Arthrodesis is a joint fusion. So this is a surgical fusion of joint surfaces. Probably the more common place we'll see this is in the spine You've probably heard of someone who's had like a cervical fusion or a lumbar fusion. And what they're doing when they fuse a joint is they're actually putting metal pieces, and so metal screws or metal plates, to fix those joint surfaces together. So these are pictures of ankle fusions or ankle arthrodesises. So it can be seen in the spine, the wrist, the thumb, ankle, very, very rarely in the shoulder and hip. I've never seen one done at a shoulder and hip. I have seen spines, I have seen some ankles as well. So they're going to fuse the joint in a position that's going to be most functional for the patient. Just keep in mind, especially with the spine, if they fuse two vertebrae together, that load is now going to be transferred to the surrounding joints. So if there was problems, or there was a problem with hypermobility, and that's why they fused in the first place, now all that motion is going to be picked up by the other joints. And so sometimes what you might see is a fusion happens in one spot initially, and then the other surrounding joints start to take up some of that slack, and then may end up needing to be fused somewhere down the road. So again, fusion is going to be achieved with pins, nails, screws, plates, bone grafts even, and they may often be immobilized either in a cast or some other type of immobilization for anywhere from 6 to 12 weeks. Post-operatively, we want to try to maintain range of motion above and below that joint as much as we possibly can, and weight bearing is going to be restricted until there's evidence of bony healing. ORIF is open reduction and internal fixation. So this is usually a treatment for a procedure done to fix a fracture. So if the fracture is comminuted, means it's just kind of shattered. If it's displaced, the bones aren't lining up, and they can't just put a cast on it. Or in this picture here, it's a clavicle. It's very hard to cast a clavicle, right? So sometimes they have to go in and put some sort of fixation in there. So this is a plate with some screws to realign that clavicle. Post-op, again, we want to try to maintain stability, get the person up and moving as quickly as we possibly can. Weight bearing may be restricted for a period of time. And because they did have a surgery, there may be some soft tissue or some wound management. Also, hardware is typically designed to stay in the area for a period of time or possibly forever, but sometimes it will need to be removed. I remember treating a patient who had some hardware in his ankle following a pretty significant ankle fracture, and one of the screws actually started to kind of work its way back out. So he had to go in and get that surgically removed. And last but not least is an osteotomy. So this is a surgical cutting and realignment of bone, often seen at the hip or the knee to reduce pain and correct some sort of deformity. Sometimes in the knee, again, because of the way that the medial compartment of the knee tends to wear down before the lateral side, you'll end up seeing a varus deformity at the knee. And so what they can do is they can sometimes go in and they can either open up the bone and then put a plate in that place to kind of hold it in that opened position, or they can take out a piece of bone and collapse it down and put some pins and screws and plates in there to hold it in that shortened position. So the idea here is that we're realigning bone to correct for a bone deformity. And again, with this may help to delay a joint replacement, but this is still a surgical procedure. So we have to outweigh or weigh the cost. Is this worth it to just try to prolong a procedure? So again, we can have medial or lateral opening or closing of the tibia where we're either inserting a wedge or removing a wedge. And those are probably going to be the most common ones that you see. So I think post-op management, recovery is going to take a while because this is removal of bone. They may be casted or otherwise immobilized following a surgery. So weight bearing is usually protected for at least 4 to 6 weeks. And then once we can get them moving, begin some active assisted to active range of motion and then progressive resistive exercises. And that's it.